Hello everyone. Today in this video I will perform the central nervous system examination. So first we have to assess the higher mental function in the CNS examination. Then we have to check signs of meningeal irritations are present or not. Then cranial nerve examination, then motor system, then sensory system, then autonomic nervous system. Then we have to check the cerebellar sign, then skull spine. So today I will cover the first part of the central nervous system examination. In higher mental function, we have to assess the consciousness, then we have to check the appearance and behavior of the patient, then orientation, memory, intelligence, speech, any history of delusion, hallucination and emotional status of the patient. To remember all these points, there is a trick ABCDE Miss O, where A stands for the appearance, B for behavior, C for the conscious level, D for any history of delusion, hallucinations, E for emotional status, M for memory, I for intelligence, S for speech and O for orientation. This trick is just to remember all the points. But in higher mental function, first we have to assess the level of consciousness. So if you find that the child is alert, awake, we label as a fully conscious. So in this video you can see the child is fully conscious and alert. If you find child is arousable but not alert, we label as a lethargy. If child is arousable by verbal stimuli, when you are speaking and the child is arousable and again go into the sleep stage, we label as a light coma or drowsiness. If the child is not arousable by the verbal stimuli, then we have to give the painful stimuli. For painful stimuli, we prefer either supraorbital pressure or we can give the pressure over the nail bed. By painful stimuli, if child is giving the withdrawal response and again once the painful stimuli is removed, child goes back to the sleep stage, we label as a stuporous or semi-conscious or the moderate coma. And last stage is coma or unconscious, when child is not arousable even by the painful stimuli. So when you are giving the painful stimuli, child is flexing all four limbs, we label as a decorticate posture. It is due to the lesion in the brain stem or the basal nuclei. If due to hyperextending all four limbs, we label as a decerebrate posture. It is because of the lesion in the midbrain between superior colliculus and pons. And if child is not showing any response, we will label as a unconsciousness and unresponsiveness to the painful stimuli. Now there is another terminology, vegetative state, coma, vigile, in which patient is unresponsive but patient remain awake and patient will gives a blank staring look. It is seen whenever there is a extensive brain damage. There are various coma scales also to assess the level of consciousness. Example, Glasgow coma scale, in which we calculate the eye response, motor response and the verbal response. Maximum score in Glasgow coma scale are 15 and minimum 3. Whenever total score are less than 8, we considered as a severe brain injury. This scale is useful for more than 5 years age group children, but for the less than 5-year age group children, verbal response in Glasgow coma scale is not appropriate. So some modification is done in the verbal response in Adelaid coma scale, while the eye opening and the motor response is similar in both Glasgow coma and Adelaide coma scale. There is another score, 4 score, which is very useful in pediatric patient, in which 4 components, eye response, motor response, respiratory pattern and the brain stem reflex. 4 score is very useful in intubated patients. So we generally use the 4 score to assess the level of consciousness whenever patient is intubated, having the altered breathing pattern, and also we are assessing the brain stem reflex in this score. So all 3 scales are very useful Glasgow Coma Scale, Adelaide Coma Scale, and the 4 score. So this is all about the level of consciousness. Then check the appearance of the child and the behavior of the child. So if you find any abnormal appearance or any abnormal behavior, example, if the child is having Down syndrome, mental retardation, then the appearance will be abnormal. Or CP child, then child will have the different look. So we will label as a abnormal appearance. Then we have to check the behavior of the child. Is the child behaving as a normal response according to the age? Then we will mention as a normal behavior. And also check the eye to eye contact is there or not, child is showing the interest in surrounding or not. If you find any abnormal behavior, example, in a child of ADHD, child will be hyperactive, attention deficit, abnormal response, example, in autistic child, they will not interact socially, not showing the interest in the social activity. Now the fourth point is ask the history of any delusion or hallucination. Both are the false. In delusion, patient will have the false belief which will not be resolved. Even parents are showing the evidence against the false belief. And hallucinations are the false sensory perception. Example, visual hallucination, when child is seeing someone which is actually not there in the surrounding. After that, we have to check the emotional status of the patient. Any abnormal, impulsiveness or excessive crying or anger is there, then we have to further ask the history part. After that, in more than 5 years age group children, we have to assess the orientation of the child to the time, place and person. In time, we can ask about the day, month or season. In place, we can ask about the is it home or hospital, then about the city and state. And in person, we can ask the name of the relative, or is the child able to recognize the relatives or not. After that, we have to assess the memory of child. It is possible in more than 5 years age group. In this, we have to assess the immediate memory, recent memory and the past and remote memory. So in immediate memory, we will tell them a brief story, and then if child is able to repeat the same story, that means immediate memory is the normal. Or we can perform the digit repetition test, which is digit forward or digit backward test, in which we will tell them some random numbers and child is supposed to repeat forward and backward. So in 6-year-old children, child can repeat up to the 5 digit forward and 3 digit backward. And in 10 years old children, normally 6 digit forward and 4 digit backward. And for recent memory, we have to ask some daily to daily activities. Example, we can ask what was eaten last night or in the breakfast. Then we can ask some specific event in the last week. And in past or remote memory, we can ask any event that occurred months to years ago. Example, we can ask some common questions also, name of the school, name of the teachers, friends, and how they have celebrated last festival or birthday. So now in this video, I am assessing the memory of a child. अच्छा चल तारे હું 3 નંબર બતાઈશ, તારે વાપસ 3 નંબર બોલવાનો, ભલે બોલશે 3 8 10 બોલીને બતાવો कौन सा नंबर बोलिया 3 8 10 શાબાશ। अब તારે ઉલટો બતાવવાનો, બસ 3 બોલી इस पर તારે ઉલટો બોલવાનો, જે છેલ્લો બોલું હું પહેલે બોલજે, ભલે 2 4 ચાલો તો જામ સીધો છે। अरे वाह शाबाश, ये तो तू सरस बताई दीधो। हाँ, अब तू ये मने बता कि तू काले राते शू खाधो तो? बटाटा। तो छेली ईद क्यारे मनाई हती? तने याद छे कोण सा कपड़ा પહેર્યા હતા ઈદ ને દિવસ? કપડા કાવે તો ઈદ બથે નવા પહેર્યા હશે ને? કોણ सा પહેર્યા હતા? કલર बताओ ना। કલર કેનો હતો? કहाँ ગયો હતો? Then assess the intelligence. In younger children, just we have to check the alertness and interest in environment, and whenever age is more than 5 years, so according to the level of schooling, we can ask the some calculation, or we can ask the days in a week or months in a year. Also check the attention span of the child by all these simple questions, and by digit repetition test also. After that, we have to assess the speech of the child. There are various level of the speech production which should be assessed in terms of expressive verbal skill, comprehensive or understanding the language, fluency and repetition, articulation, voice production or phonology, in which volume, quality and pitch, reading and writing. To assess all these components of the speech, we have to ask some simple things. Example, we can ask what is your name, where do you live, how old are you. Then check child is able to answer fluently or not. So fluency will be affected whenever child is having the lesion in the Broca's area, which is located in the inferior frontal gyrus of the dominant hemisphere. So if child is not able to express the verbal skill due to the lesion in Broca's area, we label as a Broca's aphasia. In this, child will have the non-fluent speech, but child has understand whatever we have asked. And if the child is having the difficulty in understanding the meaning of spoken words, in this case, child is having the lesion in Wernicke's area, which is located in the superior temporal gyrus. So child will have the meaningless speech because child is not able to understand. Child will have the fluent speech in Wernicke's aphasia, while non-fluent speech in Broca's aphasia. Then we have to check the repetition also. So we just say any sentence and we will tell the child to repeat the same sentence. If child is not able to repeat the sentence, that means child is having the lesion either in the Broca's or Wernicke's area. The child is having normal expressive verbal skill, normal understanding, but not able to repeat the sentence. That means child is having the lesion in arcuate fasciculus, which connect the Broca's area and the Wernicke's area. So lesion in the arcuate fasciculus will be labeled as a conductive aphasia. After that, we have to assess the articulation is proper or not. So for the normal articulation, child should have the normal vocal tract, in which nasal cavity, throat, tongue, lips all should be normal. And for assessment of the articulation, we have to tell the child to speak pa, ta, ka, in which pa is produced by the lips, ta by tongue and ka by throat. So if child is able to speak papa, tata, kaka, pa, ta, ka, that means child is having normal articulation. If you find child is not able to speak and articulation is affected, we label as a dysarthria or disorder of articulation. Example, when the child is having bulbar palsy due to 9th, 10th and 12th cranial nerve involvement, child will have the slurring of his speech. And in this, when child will speak, words will be slurred. Also nasal speech will be there. It is also associated with the nasal regurgitation, accumulation of the secretion in throat and dysphagia. In cerebellar disorder, child will have the scanning or staccato speech, in which child will speak as scanning the word. So child will speak very slowly in monosyllable or monotonous. Example, if we will tell the child to speak the ice cream, child will divide this word in monosyllable, I, sa, cre, ma. And now another disorder of articulation is spastic dysarthria. It is seen in pseudobulbar palsy in a CP child. It is because of the lesion in corticospinal fiber. So child will have the difficulty in opening the mouth. So child will not able to speak properly because child is having the spastic closure of the mouth. So child will have the slurred speech. and it is associated with the brisk jaw jerk, extensor plantar response, dysphagia, drooling of saliva. Another part of the vocal tract which can affect the speech is the nose. So sometime if the child is having the palatal paralysis, example seen in the CP child, or child is having cleft palate, then child will have the hypernasal speech. We label as a rhinolalia aperta. It is due to the defect in velopharyngeal sphincter muscle which remain open during the speech because of the cleft palate or palatal paralysis. So for the assessment of the nasal speech, we have to tell the child to speak the word which is produced by the nose. Example, m, n, nug. So mummy, nana, such type of word child will speak, and you have to assess, is it the normal nasal tone or child is having the hypernasal or hyponasal speech. So hyponasal speech we label as a rhinolalia clausa. It is seen in the when there is a obstruction in nasal cavity, example in septal deviation, nasal polyp, or if the child is having adenoid hypertrophy. Then we have to assess the voice skill, or we can say phonology, by the volume, quality and the pitch of the voice which is produced by the larynx. So whenever there is a disorder of the larynx, child will have the affected voice quality. Example of phonological disorders are, example seen in the laryngeal inflammation, laryngitis, child will have the dysphonia, painful voice will be there, volume and quality of the speech will be affected, and child will have the pain during the speech production. We label as a aphonia whenever there is a bilateral vocal cord palsy because of the involvement of the vagus nerve which supply the laryngeal muscle, recurrent laryngeal nerve, external laryngeal nerve. So in this, if the child is having the adduction palsy, then child will have the normal respiration, but the chances of aspiration will be there and there will be no voice production. If the child is having abduction palsy, then child will have the difficulty in the respiration also. In this, tracheostomy will be required. So we label aphonia due to the vocal cord palsy, bilateral vocal cord palsy. If the child is having unilateral vocal cord palsy, in this case hoarseness of voice will be there. Child will speak but the voice quality and pitch will be affected. So all these are the speech disorder. Also, and in last and higher mental function, we have to check if the child is having any release reflex, primitive neonatal reflex due to the frontal lobe lesion. Then we have to mention in the higher mental function, because release reflex normally disappear by the 3 to 5 months of age. If it is present after this age, that means child is having frontal lobe lesion. So this is all about the higher mental function. In next video, I will cover the meningeal irritation sign. So thank you so much.